But first, welcome. Thanks for coming to our first Oregon Cost Growth Target Program data submitter training. My name is Trang Weidemeyer. I'm with the Cost Growth Target Program. Just to let you know, we have other Cost Growth Target Program staff also attending the training, and they'll be available to help and answer questions as we go along. So some housekeeping notes. This whole training is being recorded. All the training materials and the recording will be uploaded later on our data submitter webpage. This is a virtual meeting, so as you come on in, if you haven't already, please check to see that your first, last name, and organization is edited in your attendee profile box. That will help with questions and logging who all is present. There will be space for questions throughout the presentation, so feel free to ask questions when we stop for them. You can also use the chat feature in the Zoom platform to insert questions there too. And we've left a lot of space, a lot of time for questions at the end of the presentation as well. So if you want to wait for the whole presentation and then submit questions at the end, that's totally fine as well. All right. So we'll just start off with the training purpose. This training is for technical staff representing payer organizations who will be compiling and submitting the CGT1 data files to OHA later this year by October 1st. Just to clarify, because I think there was some confusion on who the training was for. This is specifically for payer organization staff. The purpose of the training, we're going to go over an overview of the technical submission requirements. We'll go through the data submission template, that Excel, and we're also going to kind of highlight some areas where payers would be able to kind of customize their data wrangling and their submission. Those areas are noted in the manual, and we'll call them out here. And also call attention to areas where submission among all payers must be standardized. So the agenda for today, we're going to zoom out a little bit to talk about an overview of the program to kind of couch where this program came from and why this data is being captured. And then we'll talk about the file submission schedule, an overview of what data is captured in the program, and then we'll kind of zoom in on the data submission template, probably what you're all waiting for. This is the data submission file that you, from the payer organization, will be submitting to OHA in October. So this section is going to be a walkthrough of the template. We'll go tab by tab, looking at the contents of each one. This presentation is really big. There's a huge section of slides, slides 15 through 47, that really outlines a couple data specifications. We're not going to go through all of those slides today, and they're listed from the manual, but they will be in the slide deck for this presentation for your additional reference. So after we go through the submission template, we're going to look at a couple key sections in the manual, and then we'll finish up with data collection, a high-level look at the data file validation process, and we'll end with contact info, resources, and then holding a last call for questions from attendees. Okay. So to zoom out all the way out to the national level, Oregon is the fourth state to establish one of these cost containment programs. Some of you are familiar with this type of data, and some of you are not. The first program started on the East Coast, and we are the first on the West Coast to open them up. But you can see, looking on this map, that a couple states, including our neighbor to the north, Washington, from whom you can see I've listed this slide because it was very comprehensive. A lot of these are popping up, including active discussions underway in California. But for Oregon, this work was, a lot of you may be familiar with Senate Bill 889, which established the program back in 2019. But this initial groundwork was actually laid out in a previous Senate Bill 419, way back in 2017. This group recommended setting a target for total per capita spending. This is where accountability for payers and provider organizations started, and that's kind of the conversation that birthed this program. So this program has four overarching purposes to create a more sustainable healthcare system. The first is data cost transparency. The second is setting a growth target. Third is capturing this total cost of care approach. And this will be relevant as to why we and other states are doing this via attribution. So yeah, trying to get a handle on the total cost of care. And lastly, probably most importantly, setting a common goal for all stakeholders: payers, public and private payers, provider organizations and providers, consumers, anybody who has a stake in the healthcare system. So when this program was established, there was an implementation committee set up. Their implementation recommendations really laid the groundwork for data collection requirements and recommendations, and you can see all that in their report to the legislature earlier this year, submitted in January 2021. There's a link on the slide, also on our program webpage somewhere, probably the implementation committee webpage, for that report if you want to take a look at it. Next, again, just kind of an overall picture. We wanted to show what the annual sort of program life cycle looks like. So setting a target is certainly not the only thing the program does. There's actually a lot of stuff that happens downstream of that. So here we have, and they all depend on data collection. So once you get the data, what are you going to do with it? So yes, we are, set to measure performance against the target, but you can see a lot of the program activity depends on this data, and actually will take it even further to analyze, report, and also identify and implement actions and strategies to control growth, cost growth. So, and much of this activity on the later end will really depend on the implementation committee. So I guess I'll stop there and ask if folks have any questions so far, and see if Sarah or any team members want to add something.
Nothing from me, thanks, Trey.
Okay. So moving on in, okay, this data, we need this data. So what does the submission schedule look like? So this is an annual submission. You can see kind of the future forecast. These data files are due the first Friday of each September. That's why you see it some of the different dates here. For this initial data submission, we did push that due date back a full month. So for this year, only this year, for this initial submission, the files are due October 1st. And these files will contain 3 years of data. Moving along, let's talk about what data is going to be captured. So like other programs, Oregon's Cost Growth Target Program, we are looking at total healthcare expenditures. Total healthcare expenditures is made up of kind of 2 large components: total medical expenses and the net cost of private health insurance. For data submitters to this program, you will be submitting via the data submission template total medical expenses, so the left-hand side of this. And then breaking TME down even more, there's kind of 2 large groups we're looking at: payments from payers to providers that are claims payments, and dollars that are classified as non-claims payments. So that's kind of at a high level the data this program's going to be looking at. So as a data submitter, you're thinking, okay, TME, these are the costs. So whose costs are we including in this? So this is payment data for the following populations. It's only Oregon residents who are insured through your payer organization, and where you are the primary payer. We're collecting Medicare, Medicaid, or commercial insurance, and it's costs for their care from any provider in or outside of Oregon. This data collection doesn't include costs for out-of-state residents. So with all that in mind, some folks might recognize what we've been referring to as the triangle slide through some of our technical advisory group meetings with data submitters. This slide we wanted to put up here just to give another broad picture of the data collected. Data collected from this program are highlighted in those yellow boxes. We understand, if you zoom out and look at the entire health system universe, there are some dollars that won't be captured in this program, and that's okay. We are looking at medical expenditures, and we are looking at dollars for your data submission template. We're looking at dollars from payers to providers. And as long as data submission is consistent for each payer through time, that is what we're looking for. The intent of this program is to measure the trend of healthcare costs. Any questions so far?
Sharing, it looks like we have a question from Ada in the chat, and Ada asks, is Medicaid paying as secondary in scope?
Can you expand on that? If you're the secondary payer for Medicare, you do not want that.
Medicaid. I think the easy answer here is we only want data for members and services where you are the primary payer. No secondary payer, no secondary payments should be included at all.
Correct. And I apologize, I'm not actually able to see the chat for some reason. So Sarah
I'll monitor the chat for you. Yep.
Okay, thanks. Okay, so moving on from that, let's dig into the data submission template. You'll also see this is the Excel template. You'll also see this referred to as CGT-1. So if you look into it, you'll see there are a series of tabs. There's 7 yellow tabs. Those are to be populated by data submitters, payers. And then you'll see 2 last tabs colored blue, and those are just 2 lookup tables to help populate some fields. So the cover page is going to be, this is where you'll input payer information, contact information, and you'll answer some questions kind of to verify all the data submitted is complete. If there were flexibility in payer reporting, this is also the tab where payers will be able to give OHA some details about how they used a certain tool or something like that. And we'll go through these tabs when we open up the Excel too. But just going down this very quickly. So tabs 2, 3, and 4 are kind of related to one another. So TME, all total medical expenses for all of your members and their member months. So this is kind of like the big umbrella tab. Your members and their member months and their costs, they'll all be in this tab regardless of attribution. Tab 3 is a subset of tab 2. So tab 3, it's the same medical expenses, but it's for member months who you were able to attribute to a provider organization. And we decided to handle unattributed members in their own separate tab. So that's tab 4. Expenses for member months not attributed to any provider organization. So tabs 2, 3, and 4, you can kind of think of as a little like family unit together. Tab 5 is allocating your total member months by certain market enrollment categories. Tab 6 is for pharmacy rebates by line of business. And tab 7, lastly, was a tab we added to help with cataloging provider organizations. And that is where you can enter all the unique provider organizations in tab 3, your attributed tab, would be listed in tab 7, and that's also where you can outline any associated TINs, any sub practices or something associated with that large organization. So all you might have noticed in that brief summary, a lot of the tabs are related to one another, which we've outlined in this little schematic here. I think I'll refrain from talking about this a little bit. We will see this slide after we go through the Excel worksheet, and maybe it will, I hope it will make more sense after we actually walk through the Excel template. All right, so at this point in the training, I'm going to switch over to screen share the CGT1 data submission template. Just a reminder again, when you see this presentation, when you download this from our website, slides 15 through 47 are additional training material. This is information lifted directly from the manual. But if you want to follow along in this kind of flow we've put here, that would, yeah, you could totally do that later. I'll give you a little peek. It goes through the tabs in those slides, and actually the data specification manual pages are also outlined at the top of the pages. Okay, so now I'm going to screen share the template, and we will walk through all the slides, or sorry, all of the tabs. Right. Can someone confirm that you're seeing the submission template Excel? I'm on the first tab, the contents tab.
Trying it showing up, but maybe you want to zoom in a couple of clicks.
Ah, okay. How's that?
Thank you.
All right. So the first tab is actually the contents tab. This is what we just went over in the presentation, and it gives a brief overview of what is in all the tabs. So looking down here, here are our 7 data entry tabs, and we'll walk through what the cover page looks like. So if you've submitted this before, this will look very similar to other states. But let's go through this. So the cover page, you'll start off by giving some contact information of the payer, the contact for that organization. We also have a section below for attestation, just to make sure they're someone, we don't have like a specific title for who ought to be the authorized signatory, but we do want a sign off for someone representing your payer organization that has that, so it shows that they've reviewed the information, it is complete and accurate to the best of your knowledge, all that stuff. And if we look down to the actual questions, they're grouped into, I think, 5 tables. Yeah, 5 tables. So some of these questions are to confirm that the correct data has been compiled. And some of these are to allow you, the payer, to share details about how you compiled the data. And you'll notice some of these responses are actually a yes/no response, and you can give us more details in the comments. So please definitely feel free to use the comment cells and give us as much information as necessary for us to review the file. So table 1 is asking questions about your risk adjustment tools and calculations. We'll talk a little bit more about the criteria for a risk adjustment tool, but this is a data wrangling area where payers do have flexibility. in what tool they use, stuff like that. Table 2 looks at data completeness and estimation. So here we ask you things like, you know, what was the claims runout period for your claims? Are pharmacy rebates estimated? If so, how? And here's an example of a question that serves as a check. Does each provider organization in tab 3 have at least one pin, at least one row in tab 7? So these are helpful questions as you go along.
Hey, Trang. Trang, we have a couple of questions in the chat. Do we want to pause for a minute here?
Sure. Yeah, about the first couple boxes.
Yeah, or just they're coming in general. So Deb asks, going back to the secondary payer exclusion, Deb asks, if no secondary payer dollars are reported, what expenses should we include in line of business group number 6, Medicaid expenses for Medicare, Medicaid dual eligibles in the reporting specs? And let me try to answer this one, and I'll ask the team to chime in if I say this wrong. But for group 6, Medicaid expenses for Medicare, Medicaid dual eligibles, we are assuming that if Medicaid has paid for anything for a dual, it's because Medicaid had to. Medicaid is the payer of last resort. And so you can say, yes, technically it's a secondary payer, but in that case, Medicaid is the primary payer for those services for those dual members. So if you have a dual member and you're paying something for them out of Medicaid, you should include those costs in group 6. Does anyone want to, and on the team, want to clarify that if I said it slightly wrong? Okay, cool. Deb, flag me in chat if that didn't make sense. And then Dean asks about the data submission overall. If you have more than one legal entity as the payer within your organization, do you submit separately for each entity? And I think this is a question that we want to take on a case-by-case basis for each payer, because there might be some differences between a legal entity versus doing business as versus say, for example, a CCO that operates in multiple parts of the state, and if we want to consider those separate submissions or not. So if you have questions about whether or not you should be submitting separately for any of your legal entities, reach out to us individually, and we will have a conversation about what makes the most sense for each payer. And then third and final question in the chat right now, Dean asks, what if you use different risk adjustment tools for differing lines of business, Medicare versus Medicaid? It does not look like the tool allows for different risk adjustment tools for a payer. Sam, are you on? Do you want to take that question?
Yeah, that's a good question. It looks like you're probably specifically talking about the tab that we're on right now, the cover page, where you're indicating what risk adjustment tool you're using and what version. I'd say use the comments heavily in this case, because we understand that there will be different tools for Medicaid, Medicare. You had a really good example there. So use the comments for us, and we'll reference those when we're checking your submission. Great question.
Okay, back to you, trying to keep going.
Okay, thanks. And I seem to have locked my, okay, here we go. All right, thanks. Thanks for those questions. Keep them coming. The last 3 tables, and then we have a separate table with their set of questions for data inclusion and exclusion. We have risk-adjusted standard deviation questions. And lastly, income fees from uninsured plans to be reported. All right. Any more questions on cover page? If not, I'm going to move to tabs 2, 3, and 4. Okay, so I'm going to kind of scroll through tabs 2, 3, and 4, and then because they're kind of related, well, they are related, and then we'll stop for questions at the end of that. Oh, and I guess to let you know, this Excel has been populated with some mock data because we were getting some questions about how payers should compile the risk adjustment score for the TME All tab. So I've actually put some dummy data in here in tab 3 and 4. And if you look here, you'll see how we're doing that weighted average. Okay, anyway, I just wanted to preface that. So TME All is kind of the overarching umbrella tab that includes components 3 and 4. So here you can see we are stratifying by line of business. Year and line of business is as line of business code is the last kind of level of stratification, and you can see that here. So we have member month, risk adjustment score, and because it's TME All, you'll see there are no provider identity fields at all. There's no provider name or anything like that. So in aggregate, you'll have one row for each unique year and line of business code. That is followed by the claims costs in aggregate. We have, I believe, 9 claims category buckets. The descriptions of these buckets are included in the PowerPoint. And I guess I'll actually point you to the manual, which actually spells it out in their section. So these are the claims dollars and how they are divided. Following these claims columns, these claims fields, we have 6 non-claims categories. So we are following the Milbank Peterson non-claims categories. The descriptions for these are also in the manual. And lastly, following those claims and non-claims fields, we have a series of columns we've colored blue. You don't have to populate these. These actually will be populated. They're auto-calculated fields as you fill in these fields. All the auto-calculated fields that OHA has created will be at the end of these tabs, and they will also be colored blue. Also, another thing to note, a lot of these fields will have kind of very high level formatting checks. So this shows this shouldn't be a negative number. So if there's a value for some reason that's negative, you'll see it show up as red. So that's a basic check you can do right away as you're populating the file. And that is TME All. So all enrolled members. But what about members you are able to attribute? We'll go over the different levels of attribution later in the presentation. But for looking at the layout and how the data is stratified in the file, we've given some examples here. So you'll recognize a lot of these columns are the same columns from the TME All tab. We have reporting year, line of business code, and here we have provider organization field, provider organization name, which is required to be filled. And we do have provider last name and first name. These fields do not have to be filled. You can see up here, blanks are allowed. Somebody asked this question previously, and it's, you know, if there is attribution to an organization and maybe they just have one PC provider, these fields could be used as well, or maybe it's just one provider. Yeah, but the necessary field is this provider organization name. So these are new fields. Because this is the provider attributed tab, there is a field for attribution code hierarchy. You could look at the code hierarchy lookup table here. There's detail in the manual of what these mean. So you can see we've put some dummy data into these first two rows. Everything for these first two rows is the same except the attribution hierarchy. And we do require that you stratify them by row. That's why this field is here. So again, member month risk adjustment score just for this group of member months. And we have the same claims categories following these initial fields. So this is in aggregate those claims dollars in those 9 categories. Following that is the same non-claims categories. And the last field in this provider attributed tab is risk adjusted standard deviation of Pmpm. We're requiring this. This is a part of Oregon's statistical testing methodology to be able to make those confidence intervals. So we can say with certainty, with statistical confidence, that yes, this is above the target, or no, because the confidence intervals straddle the target, this is not statistically over the target. Our group did put together this supplemental standard deviation calculation Excel, and Yishan is going to give us a brief walkthrough of that after I finish with these tabs. So that is the last field payers will populate for TME PROV. Here are the same auto-calculated fields at the end. So I'm going to move on to tab 4, the unattributed tab. So these are for member months, members and their months, where you were not able to attribute them to a provider organization. So in this tab, this is reported in aggregate, and we are stratifying by year and line of business code. So for each unique year and line of business code, there's going to be one row. You'll see dummy data populated in here. And moving along from left to right, we have the same claims field, same non-claims field. And then we also have that risk-adjusted standard deviation of Pmpm for each row. See the spread of data. All right. So keeping in mind, Yishan's going to walk us through this supplemental Excel that she's painstakingly made. Before I hand it off to Yishan and we kind of walk through that supplemental Excel, do folks have questions on the layout and stratification? Any questions about that for tab 2, 3, or 4?
Trang, I want to raise one question from the chat. It's been asked and answered in the chat, but I think it might be helpful to actually say it out loud. Dean had asked if, just to clarify that, will tab 2 should equal tab 3 plus tab 4, and will there be an error in validation that spits out somewhere if that doesn't add up? And our answer in chat is yes, that should add up. Tab 3 plus tab 4 equals tab 2. It's something that OHA will be looking for on the validation checks that we'll be conducting. We talked about those in our last tag meeting. We might talk about them at the end of the training today, but it's not currently built into the template to auto flag that as an error. It's something you can look for. We encourage you to look for it, but it's not set up to actually give you an error in the template. That's on our wish list of future improvements to the template.
Yeah, for the template next year, we're really hoping to build in a couple auto-calculated summary tables so payers can see the results of all of those kind of comparisons and checks across tabs. Any other questions about this family of tabs, these groups of tabs? Okay. Well, now let's talk about this special field, risk-adjusted standard deviation Pmpm. So now I'm going to screen share. This is also uploaded on our data submission webpage. I don't know how many people had a chance to look at it yet. It is a lot to look at, but it's, we hope, very helpful. All right, so now I'm going to screen share this Excel and hand it over to our analyst, Yishan, to walk through it. Let me know if I need to zoom in.
It looks fine from my side. Anyone need this to be larger? All right, so I'm Yishan Song, a research analyst with Cost Growth Target Program, and I'm going to walk you through the example of how to calculate the standard deviation. This Excel sheet is also being posted on our website, so you can always refer to this example when you are preparing the data. So before I go to the detail of this example, there are 4 key points I want to mention. So first, when you report this standard deviation, make sure you report the risk-adjusted values. This is different from what you report the dollar amount, the payments in the tab 2 to tab 4 that we ask you to report the unadjusted payments, and then you report the risk scores separately. But for the standard deviation, you need to report the risk adjusted values. And then the second part is that when you report a standard deviation, it is calculated on a basis of per member per month. It is not based on the member level. So you need to calculate the Pmpm for each member before you can do the standard deviation calculation. And the third point is that when you calculate standard deviation, make sure you only use the claims-based payments. The reason is that the non-claims payments, it may be very hard to allocate to a member level or member month level. So when you do the standard deviation calculation, only use the claims-based payments. The last point is that when you calculate standard deviation, make sure you are using the population standard deviation equation, which means the denominator is big N. You cannot use the sample standard deviation equation, which the denominator is N-1. So to make sure you use N as the denominator when you are calculating the standard deviation. So let's go through this example. This example is only for one pair in one line of business. And here we use the line of business commercial floor claims as an example. But you can always apply this logic and method to all other lines of business you are interested in. So the step one for this standard deviation calculation is that you need to attribute the members to appropriate provider organizations using the attribution hierarchy we documented in the manual based on the member months. And for the members you are unable to attribute them to any provider organization, then you will assign their member months to the category, which is unattributed category. Here is an example, a few things I want to point them out. So for member one, because the first 8 months are with another payer, so you don't need to worry about the dollar amount, the 8 months here. You only really need to focus on the 4 months that are with you, and then they are attributed to the hospital system Z. And for member 5, it is very possible that you have members that switch from one provider organization to another provider organizations within a calendar year. In that case, you will have 2 Pmpn calculate for the member 5. So you will have one Pmpn, which is attributed to a hospital Z, and then the other Pmpn, which is attributed to the mainstream provider group. And similar to the member 7, if you have members switch from attributed to one provider organization, then become unattributed, then you will have 2 Pmpms for these member 7 when you calculate standard deviation. So let's go to the step 2. Could you scroll down? Yeah, thank you. So yeah, once you have all the member months being attributed to the proper places, the second step is to calculate the risk-adjusted Pmpm for each member. So here I'm going to take a member 1 as example. So for member 1, because the first 8 months, you don't have any dollar amount for this member because they are not with this payer. So you will only need to worry about the last 4 months, and then you report the dollar amount here. And just to make sure these dollar amount are all from the claims payments, there's no non-claims payments here. And to calculate the average Pmpn unadjusted value, you simply just sum up the dollar amount from these 4 months and then divided this value to 4, which is the number of member months for the member 1. Then you get unadjusted Pmpn. To get the risk-adjusted Pmpn, you simply use this 225 value divided by the risk score of member 1, which would be 1.29. Then you will get this $174.42 dollar amount for member 1, the Pmpn, and it is a risk-adjusted. And you will do the same thing for all other members. But just to make sure that for member 5, because it switched from one provider organization to another, so you will have 2 Pmpms for this member. And similar to the member 7, you will have 2 Pmpms for member 7 as well, because it switched from attributable to one provider organization to unattributed category. And just want to note that this risk-adjusted Pmpn is exactly, if you go to the step 4, you will see the standard deviation equation. That is the xi you need when you calculate standard deviation. So let's go to the step 3. So for step 3, once you have a Pmpn for each member, the step 3 is to calculate the total member months and the total the average risk-adjusted Pmpn by line of business, by provider organization, and by attribution hierarchy. So let's take this column as an example. the total member months is really simple. You just sum up all the member months from member 1 to member 3. So you will get a 28 here. And then the risk-adjusted total claims payments. If you click this cell, you will see it is actually, you will multiply, you will use the value 174.42 for member 1, multiply the member months for member 1, and then plus the 267.1, multiply the 12, which is the member months for member 2, and then plus to the member 3. So you basically, it's kind of like a weighted Pmpm for not weighted Pmpm. It's like a weighted sum of the dollars amount from member 1 to member 3. So that's the risk-adjusted total claims payments for here. And then to calculate the risk-adjusted Pmpm, you will simply use this 7,069.89 divided by the total member month, which will be 28, and you get this average risk-adjusted Pmpm for this column. And you will do the same thing for all other columns. So that's how you calculate total member months and the average risk-adjusted Pmpm for by line of business, by provider organization, and by attribution hierarchy. And the total member months is big N, that you will see in the step 4 in the standard deviation equation, and the risk-adjusted Pmpm is X bar, you will see in the step 4 here. So now you have the Xi, X bar, and then big N. Now you can do the standard deviation calculation in the step 4. In the Excel, you can use the function which is called stdev.p. That's the population standard deviation function. It's in the rule 86. Here I want to point out that when you fill out the dollar amount for member 1 or any members, you are not using the actual dollar amount you've been paid for them for each month. You are actually using the average Pmpm for this member. So you will see like for member 1, you have 4 member months for them, and we are not using actual dollar amount you see in the step 2. We are using the risk-adjusted Pmpm. The reason is that this standard deviation is trying to capture the variations across different members. We are not trying to capture the variation within one member. So that's why we use the same Pmpm for each member. But because this member have 4 member months, so you need to count 4 times for this one. And that's how you calculate standard deviation. And if you are not using the Excel sheet to do the standard deviation calculation, you can always refer to the standard deviation equation when whatever software you are using. And that's how you calculate the risk-adjusted standard deviation in step 4. So once you have the standard deviation being calculated, the last step is just to fill out these numbers into a proper place in step 5. So in step 5, if you are reporting the provider organizations using different tiers, you will report this number into the tab 3, which is the TME provider organization. And if you are calculating the standard deviation for the unattributed member months, then you will report them in the tab 4. So that's all the walkthrough regarding the standard deviation calculation. Does anyone has any questions? You can also ask a question at the end of this training, and I'm going to hand it back to Chen to talk about more tabs in this data submission template.
All right, thank you, Sean.
And we don't have any questions about the standard deviation calculation in the chat yet. So I think keep going.
Okay. I tried to be your Vanna White with your walkthrough. Okay. So thank you so much, Yishan. I'm going to switch back to the template. So that was, but just to recap, we went through tabs 2, 3, and 4, and then we had a walkthrough of this supplemental Excel our team made to help better understand and get at this risk-adjusted standard deviation, Pmpm. And now I'm going to just roll on through. We're on tab 5, which is market enrollment. Let me scroll up. Oh, let me zoom in. Okay, so the market enrollment tab is split up between the 3 years, because we have 3 years of data submission in this initial submission. So this tab is pretty self-explanatory. It's asking for member months allocated to any of these 8 market enrollment categories. Are there any questions on this tab from people? Okay. Rolling on through, we've got tab 6. This tab is to record your pharmacy rebate information. The level of stratification here is by year, and within a year, stratify by line of business. We have breakouts for medical pharmacy rebate, retail pharmacy rebate, and total pharmacy rebate. Any questions so far?
Nothing in the chat yet.
Okay, thank you. I am keeping, I am watching that clock. So, yes, okay. And well, we're on our last tab, hooray. So our last tab is for provider organizations and any of their associated TINs. So here, I've given an example in some of our TME All, PROV, and Unattributed tab. We have Hospital System Z and Clinic W. So there are 3 TINs associated with Hospital System Z. So you can see Hospital System Z exists in 3 rows. And we do want to make sure that each unique provider organization that is identified in that 3rd tab also exists in tab 7, at least once. And then the last 2 tabs of the data submission template are just lookup tables for line of business and attribution hierarchy. Any questions on these last tabs? All right. Let me go back to our data submitter slideshow. Okay.
We have a question about the market enrollment tab. Dean asks, on the market enrollment tab, say you have 5,000 Medicare Advantage total members and 2,000 of those also have Medicaid. Do you report 3,000 on Medicare Advantage and 2,000 for duals? I want to say yes, but team, someone want to confirm that?
For duals, yeah, sorry, and I'm trying to get to that market enrollment tab.
And Ada says, keeping in mind that they're different companies. And I think this gets to the question earlier about which companies versus which organizations are we reporting in the same template or not. And that's where there might be some individual payer discussion needed. But let's assume they're all the same. Let's assume you're reporting all of them in the same template. You would report duals as duals, and those that are Medicare Advantage only as Medicare.
Okay.
I'm also wondering, based on some of these questions, if it wouldn't be helpful to have some additional CCO specific guidance around how CCOs should handle some of this reporting.
Yeah, I think that would be really useful. We have a little bit of that right now in the manual that we've been able to anticipate. Yeah, but it sounds like we might want to put a little bit more guidance. Okay. All right, so these slides, so slides 15 through 47 are also a walkthrough of the tabs. And if you're, going to be looking at this presentation again, I would recommend, it might be nice just to have this slide open, and then right next to it, open the template and kind of follow along with each other. So here's that tab relationship slide we saw earlier. I hope after walking through all of the tabs in the CGT1 file, this slide might make a little more sense. We've seen that for multiple variables, so for claims and non-claims variables, tab 2 will equal tab 3 and tab 4. But I'll note, just to make sure that you're aggregating or folding up at the correct level. So this is per year and line of business, because those are all present in these tabs. So per year and line of business, these should correspond to each other. TME all is also related to the Market Enrollment tab. The Market Enrollment tab has, I think we showed 8 or so Market Enrollment categories, but when you fold them up into, commercial, it should correspond to the commercial rows in TME all as well. And as we noted before, the third tab, which identifies provider organizations, each unique provider organization in tab 3 should also be in tab 7. Next, we're going to walk through some sections of the manual. Sarah, please let me know if there's any questions we should take care of before we get in here.
There are a couple more CCO specific questions that are coming in. Let's keep going, Trang, and I'll respond in the chat.
Okay, great. So the data specification manual, so this is where we're going to provide your technical specifications, and it's broken up into many sections. Here's an overview of what it entails. We're going to pull out and talk about some key sections, especially because they may be sections where there's flexibility in reporting for payers. So the manual has, specifications for what you must report by, and whenever you see this icon, this kind of adjustment icon, that denotes an area where you have flexibility, and we'll talk about those coming up. So the first one we want to talk about is primary care-based member attribution. So for our data template, we have this divided up into 3 tiers. Tier 1 is called member selection. So this is attribution of members and their months to a primary care provider in plans who had members that were required to select a primary care provider or primary care home. So that's, you know, probably pretty straightforward. There's a direct attribution right there. So that we're calling tier 1. Tier 2 is contract arrangement. So for members who aren't in tier 1, you may be able to attribute them to a primary care provider or a home pursuant to a contract between you, the payer, and the provider. And an example is, you know, if a provider is engaged in a total cost of care contract, then you, the payer, can attribute that member to that provider and thus report that provider's organization. And then you would denote that in the data file as tier 2. Tier 3 is utilization. These are members who cannot be attributed in tier 1. You cannot be attributed in tier 2, but you, the payer, may be able to attribute them to a primary care organization based on that member's utilization. And this is using your own internal methodology. We have some guidance to help with this, but this is an area where there is flexibility, and based on what methods a payer may have internally, you should definitely use that, and we may follow up with you to get more information on how you're doing that later on. And for members who just cannot be attributed to a primary care provider or home, using any of the 3 tiers above, you can report all of those members, their member months, and their costs in that tab 4, the unattributed tab. So that will be reported.
We have a question about attribution. Feels like a good time to drop it in.
Yeah.
Should the attributed tab only have primary care providers? Your example had hospitals. Can you talk about the primary care roll-up?
Yeah, and other folks on the team should feel free to jump in too. So we're calling this primary care based member attribution. If that primary care provider belongs, if they're affiliated with a higher provider organization, such as member or hospital system Z, you can fold it up into that provider organization. Does that make sense? I think maybe this next slide could illuminate that a little bit. So members will, you can attribute members to a primary care provider. Multiple primary care providers may belong to an organization, and that organization is reported in tab 3. So it could be like a pretty large grouping. In tab 7 is where we're requiring, it's where we're collecting any TINs associated with a provider organization to be documented. And we added this tab 7, because we know there are going to be differences between payers' files, and what might be a provider organization for one payer might be a TIN for another. So, and this is an area where I think, we don't really know what this is going to look like or how well we'll be able to parse this out until we actually see the data.
So I want to pause and make sure we answered Donna's question about attributed. So looking at the graph on the bottom of this slide that Trang has up, individual members are attributed to individual primary care providers. The individual primary care providers get then rolled up to the larger organizations, and what's reported in the data submission template is at that larger organization level. Does that make sense? Is more clarification about the attribution needed? Okay, we have confirmation. Thanks.
Okay.
We have, new follow-up question. Angela asks, what about provider organizations with multiple TINs?
If one provider organization has multiple TINs, I think, especially for this initial year of reporting, I would say, and back me up or not, Sarah, that we would want those TINs.
Yeah, we're trying to, yes, we're sort of casting a broad net. And I think as Trang was explaining, between tabs 3 and tab 7, we're trying to create our own mini directory of this. So if you have a provider organization that has multiple TINs, please list those in tab 7, and that will help us group provider organizations together. We know that in some cases this might be labor intensive, and so we're trying to roll this up to the highest level possible. We ask you to try to roll up to the highest level possible, so that you're not listing hundreds or thousands of numbers. That's one reason why we went with TINs instead of NPI. But yes, recognizing that some organizations do have multiple TINs, and if you know those, please list those out in tab 7.
All right. So we have a couple more slides to go, and we have 15 more minutes. So I think I'm going to try to complete all these slides, and if folks have other chat comments, please put them in the chat, and we'll definitely take a look and follow up later if needed. So one big area where payers have flexibility in reporting is their health risk adjustment tool. In the manual on these pages and shared on these slides, we outline certain parameters for your health risk adjustment. Some payers have contacted us early with some questions about this, and maybe the tool they use is appropriate, but it doesn't fulfill one of the criteria. And if that's the case, for this first year, please reach out to us and let us know what's going on, and we'll take it from there. But these are the parameters for the health risk adjustment tool. Whatever you're using, report it to us. There's that section on the cover page where you can report the tool, the software, the version, and all that. Going through this, and these are directly listed from the manual, but we do want to highlight in this training seminar, there is a section in the manual that talks about inclusions and exclusions. We have specific call outs for Medicaid CCOs on page 20 of the manual. These are some other areas where we've anticipated questions, or we've received questions early from the tag group. So these excluded items are excluded from the TME. This is a non-exhaustive list, and if there's other things that pop up as payers are compiling the data that they're unsure about, please reach out to us directly at our email. So an example of an excluded item is dental and vision services if it's not covered as part of the medical plan. So no standalone dental or vision. So that's an example. For data completeness, please allow for a 180-day runout period after December 31st of the measurement year. There's sections on the cover page for payers to report their level of completeness. For non-claims estimation, there might be areas where payers might need to apply reasonable and appropriate estimations. And if you do that, there's an area on the cover page where it asks if you've done that and what were the details, and you can add those details there. For carved out services and vendor payments, please refer to these manual pages we've referenced up at the top, 24 and 25. In brief, if it's a covered benefit, it should be included in the TME data submission. So if you have encounter data, payers should estimate and include it in the TME. If you do not have access to claims or encounter data, apply a reasonable estimate. And again, once again, if you've made estimations, please give us details of your methodology on the cover page. Regarding administrative fees, so we are going to be looking at the NAIC medical loss ratio forms and whether or not it's included or excluded in those forms. Include or exclude them from this data submission, except for contracts or vendors that provide strictly administrative functions. If it's strictly administrative function, do not include it in the TME calculation. Next, we'll talk about data collection and validation. These will be emailed Excel files. You'll email directly to our program inbox. The email is here. For file naming conventions, we point you to the manual page 28. Once again, those files are due by October 1st. And then the last few slides are a little bit about what our steps are for validating the data. So just keep in mind, this data validation is only relevant for individual payer files. So we're doing them in 3 stages. Stage 1 is an initial review of submission, looking at large structural issues. Stage 2 is a more detailed review of the contents of the data submission. The results of what we find in stage 2 we'll share with payers in stage 3. And validation documents, we did share the validation draft plan with TAG members, and we got some good feedback, some good thumbs up. So we are finalizing those documents, and they will be posted on the submission webpage. This slide is kind of a brief overview of these 3 stages. Stage 1 is looking at large structural issues in the data, making sure that the cover page has all of those questions filled out, stuff like that. Stage 2 is where we do some more in-depth data checks. We'll create summary tables showing the results of those checks, and that will be shared with payers in stage 3. So this is kind of a check. Does this data look right? Is there something amiss? Do you think you need to resubmit? If resubmission is required, we'll start the validation process again from stage 1. And when the file is deemed, okay, this makes sense, this is what we're looking at, we'll consider that single payer file approved, and that file will be moved along for statewide analysis. I will note at our last TAG meeting just last week, I believe, payers voiced a preference to have status reports, maybe weekly status reports on how validation is moving along. So we're developing that into the process as well. This is a timeline for collection and validation. This is a very tentative timeline. We don't know. We can't give a hard timetable for validation because we've never done this before. We don't know what the data looks like, and we're not sure how much time validation is going to take. It might take a long time. There might be resubmissions, or it might go very quickly. But once data is submitted in October, that fall we'll be validating the data, and we'll also be prepping analysis for the first annual report. There's no hard date for that annual report yet, but it will be in the spring of next year. And in the spring of next year, by August 30th, the latest, payers will be notified of their 2022 data reporting status. And the deadline for next year is going to be the normal standard deadline of 1st September. So for next year, that's September 2nd. We want to show on the data submission webpage, there are a lot of resources out there. The data submission template, this is the file you'll be very familiar with by the end of all of this. Here's that data specification manual. I'll make a note, we are planning on updating this manual in August. We want to wait for some feedback from this training and maybe at least the first office hour next week. But there's an update plan for the manual. A lot of data submitter questions and kind of maybe more granular questions and stuff we are putting into this data submission facts document. This data submission facts document will be updated on a more frequent basis. Watch out for that here.
I just want to clarify for everyone, when we say we're updating the manual, we are not changing the rules. These are not major changes. We've had some requests from data submitters that content that we're putting in the FAQs be also incorporated in the manual so that everything's in one place. And I think some of the questions that are coming up today, maybe about some CCO specific guidance, those are the kinds of things we'll be adding to the manual. It'll all be clarification. It will not be a change in direction or policy.
Good call out. And then we have some supplemental documents. This is the standard deviation one that Yishan walked through today. And you take a look at these if you wish. And we have 6 minutes left. So now let's open it up for some last minute questions. We do have 3 office hours planned coming up. These are Teams invites. So if you would like that email, please email our program for that Teams invite. Or if you have a coworker that's going, just have them forward it to you. All right, well, with 5 minutes left, are there any questions in the chat you think would be good to go over in these last 5 minutes, Sarah?
I don't think we have any new questions in the chat. I do think there are a lot of questions about how to handle duals, especially how CCOs should handle duals. So we will follow up on that. And I think let's use the August 9 office hours for some additional discussion about duals. Questions are coming in right now. Okay, so Quinn asks, will you be posting the template with the sample values populated?
Yes.
Okay, we'll push an update out to the tag list and all the attendees today when these slides, the recording and the updated template are populated?
Yeah, we could do that.
Okay. And then Kyle asks, you mentioned specifications for non-claims. Milbank, can we include that? And Kyle, I'm not sure if I'm tracking your question here. In the manual, there is quite a bit of description of the different non-claims categories. It's not the same as a code set, but there is a lot of description of what types of payments should be included in those non-claims categories. Is that what you're asking about, or did I misunderstand? Oh, okay, good. Kyle's good. Thanks.
Okay.
And again, just continuing to encourage people, please send in questions to our program email at any point. We've already had a lot of questions come in from many of you, and that's been really helpful in identifying where we need to provide some additional clarity, where our guidance is confusing, and where we might need to build something out a little bit more. Your questions have really been the foundation of that first iteration of the FAQ document, and we really appreciate all of your engagement and close reading of all of our documentation. Please keep the questions coming.
Yes, your engagement is greatly appreciated. I feel like a robot. Anything else?
Nothing's coming in chat.
Okay. All right. Well, thanks for attending our first initial data submitter training. Once again, the recording and the slide deck and the mock Excel sheet will be posted on our data submission webpage. And when it does, we will push out an alert to our tag listserv. And to everybody who attended this meeting too, we can do that. Okay, thank you for your time and have a great rest of your Wednesday.
Thanks, everyone.
Bye, everyone.